A lot of talk, obviously, over the last few years about the opioid crisis, addiction crisis more broadly. Where are we at on all of this? So joining us in studio, we have Dr. Shawn Ryan. Shawn is one of the founders of Brightview. Where are we at right now? We hear anecdotal evidence that things are getting better. Deaths supposedly are going down, more availability of beds. So it seems like we're heading in the right direction with this addiction crisis, but are we really?
Yeah, I would say we are in general. So, the CDC or the mortality, overdose death data appears that we might have crested this past year. The problem is we're at the top of Everest. So, right, all those people that are unfreezing in Everest because of global warming or whatever, that whole thing, we are at the top. And last time I checked, you have to come back down or you stay forever, right? So the problem still is, given the baseline of the 80s and 90s, we are so far above where we were, we have a long way down.
So it's just a matter of we're leveled off and we're starting to come down the backside of the mountain here.
Yeah, through a lot of phenomenal efforts, especially here in Ohio, by the state, governors, previous and current, a lot of very hardworking people in the different departments of mental health, organizations like Brightview Health that have expanded over the past 5 years substantially. I mean, public health has played a huge role in distributing Narcan and syringe exchange, all this stuff. It's a lot of very good efforts, and that's what it took to just stop the madness of where we were going.
And that's the scary thing. I guess now, though, we are getting better at dealing with this. Aren't there new approaches and things that we can look at and say, okay, we're making progress here?
Absolutely. So at Brightview, we really focus on the medical evidence and the science of how you should treat people with substance use disorder or opioid addiction in this case. And one of those things is medication-assisted treatment. It's not an opinion. It's not a philosophy. This is science. We know that it's the best treatment as part of the holistic plan for a patient with opioid use disorder. It's not up for debate. I'm happy to have one if someone would like to, but it's not going to go well because we're talking about hundreds of thousands of patients, science-based articles, and decades of evidence telling us that's the right thing to do.
So walk us through it a little bit, and why does it work so well?
Right, so the brain's a very complicated thing, and we're still learning a ton about it. So those of us in medicine for a long time still, kind of fascinate about the fact that this is kind of the last frontier above the neck here. And so we're still learning a ton about what it is. But what we do know is that particularly with opioid addiction and other addictions, the neurochemistry is off for a lot of different reasons. Genetic, environmental, exposure to drugs, whatever. And the most important thing you can do, particularly with opioids, is to stabilize that. But there's also, other substance use disorders, same kind of thing. Alcohol use disorder, stimulant use disorder. We have medications that work. And so we know that those medications, particularly medication-assisted treatment, in this case, it's methadone, buprenorphine, and Vivitrol are the 3 FDA-approved ones. Those things help to stabilize that brain chemistry. Without that, people do very poorly. 90+% relapse rate without medication. And unfortunately, I've recently received data both in the state of Ohio and nationally from different folks. We're still only getting about 1 in 10, maybe 1 in 5 in the good areas, but maybe 1 in 10 patients on those medications. In contrast, for diabetes in this country, we do a phenomenal job. We get 85% of people, not 10%. We get 85% of people on medications for diabetes in this country, and that is where we need to be.
So where's the disconnect here? Why aren't we getting more people on this kind of deal?
There's a lot of issues. I mean, number one of which is stigma. We still kind of think that addiction is a moral failing. It's a choice. It's not. I mean, I give lectures on the 3 factors of addiction being genetics, environment, and exposure. Very little of those 3 factors are actually controlled by the person. We use wrong terms like drug of choice. I don't know how many people you've talked to in the throes of addiction. Nobody is super excited about being in that situation. Right. Like, I can't wait to go eat at Luigi's in about an hour. I am very excited about that.
Yeah.
Right. That is a way different sentiment than I have to get to this opioid or heroin today.
Yeah. Nobody's saying, "Ooh, hey, let's go." No.
I love ruining my life. This is awesome. My family's mad at me. I have no money. My physical health is bad. Like, it's insane to think that's a choice someone is intentionally making.
Right.
Yeah. So stigma is actually the biggest problem we have, and the beliefs that the public have about what people are doing. Then the things that they get kind of wrapped around, well, I don't, quote, believe in this medication or whatever. I don't have, as a scientist, I don't have that luxury, just to be very clear. I don't have the ability, I get to believe in Jesus Christ. That's a way different conversation. But I don't get to believe in science. If you come to me for a blood clot or diabetes or whatever, I'm morally bound. I took an oath to treat you with the best science I know how. And this is the best science. And other barriers, there's a lot of things. Even the patients are worried about it. Well, this certain drug operates on this certain part of the brain. Right, that's my job. My job as your physician to help you understand what that means.
Is some of it cost? We all know about the crisis in paying for medical care right now. And if somebody has lost everything as an addict, they probably have access to the medically assisted recovery and having that paid for. But if somebody is working a low-wage job and has one of the government-offered healthcare programs, will that pay for the medically assisted recovery?
Yeah, so for the most part, yes, and that's been an increase over the past 5 years. Most insurance companies have, really taken up this. In fact, the data I got from one national company was they were very upset. They actually only had 16% of people on medication-assisted treatment, nothing to do with their policies. Literally just people not going to get it, people not offering it, et cetera. So yes, in this case, most insurances are really supportive of this. At Brightview, we take a ton of insurances. That was something that we very intentionally started years ago as part of our mission. I said, I don't want anybody to be worried about what it is that they have. That doesn't mean you can take all of them because that's impossible. Not even every hospital does that, right? But we take, it's like 55, 60 payers right now, different insurance types, Medicaid, Medicare. Medicaid expansion in Ohio has been very important, so we're lucky that the previous governor and current are very supportive of that. So there are a lot of resources for people to get on medications based on insurance support.
Another one of the barriers here in Summit County is addicts have told us it takes me all day on the bus to get to the one facility where they have to distribute it every single day, and then it'll take me all day to get home. I can't get a job. I can't get ahead. My entire day is consumed with getting my medication.
That's a real thing. It's a real problem. And so what you're describing is actually the methadone distribution federal regulations. They have to do that, the daily things for 90 days, 6 days a week, all that other stuff. It's an issue. That's one of the reasons why Brightview actually primarily uses buprenorphine. We do run those federal opioid treatment programs within our facilities, but the buprenorphine gives us more latitude not to do that every day. That's a real thing. In fact, some of the treatment programs, you talk to people like, I have 18 visits this month at 3 to 6 hours per day. And I just say to people, if I asked you to, hey, I need you to be somewhere at 6 a.m. for 6 days a week for the next 90 days, is that happening? No.
Probably not.
I can tell you right now.
Probably not.
So this is where Brightview and a lot of others are working on access problems like that. Transportation, we have Lyft and Uber partnerships to get people where they need to go a little bit more efficient than the bus. And then I was on the phone with our chief clinical officer, our new one, Dr. Navkang. Very excited to have him on board this morning about Lyft programs, and we're going to work with the Lyft worldwide impact channel and strategy. So, we're working on all those things. I will say on the cost and the other things. We're spending a lot of money on a lot of treatment that's not working. So a lot of these detox programs that don't have a long-term plan for the patient, that doesn't work. Residential is important for some patients, but not all. About 1 in 5 is what we know from the data. And so we need to be, and Brightview and others at the state, I sit on the Recovery Ohio Council for the governor. I feel it's fiduciarily responsible. We need to be careful with our money that we're spending to make sure we're doing the right things.
One of the other criticisms that I hear, and we're talking with Dr. Shawn Ryan from Brightview on 1590 and 93.5 WAKR, it's not as much a criticism maybe as much as it is, medically assisted treatment is a great start, but there needs to be more around the patients than that. So are you taking care of those things too?
That's exactly what we do. So when I use the biopsychosocial term, that's exactly what Brightview does. You have to address the patient, the whole person. A colleague at one of the agencies here in the state calls it find the neck, meaning don't just think this one thing is the issue. There's a whole person you got to deal with. And so at Brightview, when you come in, we do that full holistic assessment. What is your social situation? What are all your medical needs, including are you smoking? That's actually still a big problem, by the way, in our country, in our state. And what is your housing situation? What is your trauma history? Your psychosocial trauma history? Were you abused? Those kind of things all have to be done, and appropriately so, in a state certified program like ours. And we try to address all those things. Now you got to address them in different percentages and modules. And this person's abuse history may have been way worse than the other guys, or whatever. But that's why we have a multidisciplinary team. I'm a physician. We have a lot of very well trained therapists, social workers, and peer supporters. Huge part of our program are folks that have been through that experience and are able to connect with a person on a level that I can't. And that's okay. That's why we have a team.
Very good. Bobby, sorry.
We opened the show today with a tragic story about a baby in Springfield, an infant, 3-month-old. And alcoholism has been overshadowed the past bunch of years, of course, by heroin. It is still a gigantic
Very big
problem. Now, the only medically assisted recovery I've ever heard of is ancient Antabuse, I think. And the way it worked was you take the pill, and then if you drink, you just throw up all day.
It doesn't work very well, not surprisingly.
I'm hoping there's been some progress since that.
There absolutely has. So at Brightview, there's a couple of other medications that are FDA approved for alcohol use disorder, which is a huge problem. There's still actually very many more people with alcohol use disorder or alcohol addiction than there are with opioid addiction. And so we do treat that. In fact, I was on the phone with our medical director down in Centerville today about a patient who needed treatment, detox, using the right medications, or withdrawal management is the more appropriate term. And now we have injection Vivitrol as an example. So Vivitrol is good for opioid use disorder or opioid addiction, but it's also good for alcohol use disorder, and it's something that's very underutilized. It's good at suppressing those cravings for people to go back and drink, keep them in remission from drinking, etc. And there's other medications as well. We can see with the right medications and the holistic model, absolutely see up to 75% reduction in heavy drinking, which is a big deal for a patient like what you're talking about who unfortunately put their child in a lot of danger.
And no puking, as Bobby alluded to. No puking.
It kind of makes a little sense if you don't know about addiction and alcohol use disorder or whatever, but realistically almost no one is ever successful on antabuse. It just doesn't work.
We're running out. Go ahead, Bobby. We're running short on time, but we got time for a couple more.
If somebody walks in and said, okay, I'm done, do you see them right away, or do you have them sit in the lobby for 8-9 hours, or ask them to come back another day, or tell them we don't have beds for 2 weeks?
Yeah, we don't do that. So we're going to see that patient. We do a lot of staffing complexities to make sure that there is a physician on site or another advanced nurse practitioner or whatever to see that person immediately. They get a counselor gets to do the psychosocial assessment. We try to make a plan with them, and it get complicated. If that lady walked in with a kid, we'd be dealing with the kid and all that other stuff. But we are definitely not going to turn them away. And everybody at Brightview knows that if that happens, I'm going to hear about it same day.
There you go. So Brightview grand opening this evening, right?
That's correct. I'll be there.
Tell us a little bit more about what we're going to see, where we need to go, all of that.
So that please do visit our website, www.brightviewhealth.com, and you can find the Akron site and the address there. I have some colleagues here with me in the studio that will be there with me. We're just going to talk about what we're doing. We're going to talk. We want people to see the site. One of the things people get worried about with going to a rehabilitation facility or alcohol, addiction treatment facility, is they feel like it may not be very nice. Right? Some of them are very nice that people can't afford, like Malibu or whatever.
The ones you see on TV in the commercials, right?
That I couldn't afford, right?
Yeah.
So, but that's not. We want to make sure people know this is a nice, warm, welcoming place that is well put together, well designed, and looks like a medical office, and is supportive of people that are looking for help, no matter what their situation might be.